everybody. Just going to give everybody another minute or so to get logged on. While we're getting everybody logged on, I just want to quickly introduce myself. My name is Shannon Marks. I am the Inside Sales Manager for the West region for Tim's Medical. I'm also a speech pathologist, and I'm filling in for Brooke tonight. So I'll be kind of going over some of the housekeeping information for ASHA CEUs before we get started. So the course is eligible for 0.1 ASHA CEUs. In order to obtain the CEUs, we just ask that you complete a quick survey, which I will put in the chat. And the link will also be available on our website and sent out via email from Zoom within a few hours of the course. And at the conclusion of the course, we're going to do a Q&A session to ask some questions. But if anything comes up during the course, please feel free to put your comments or questions throughout. And lastly, the course is free, but we are raising funds for healthcare professionals impacted by Hurricane Helene. So if you're able to donate, we have a link that I'm going to put in the chat. And with that, so we're at 8:01 Eastern Time. So I will kick it off to Laura to start our course on safety, standardization, Swiss cheese, and the SLP.
Thank you for having me. I'm very excited to be here. Thank you, Tim's. Thank you for giving me this opportunity to speak on probably my favorite topic, which is patient safety quality. I am a patient safety professional, among things. And really being able to speak about this is probably one thing I love. It's you can see it just is in everything that we do, and I love sharing patient safety science, not just with speech pathologists, but with other allied health professionals and people who are trying to learn more about speech pathology and its connection. So I'm going to go ahead and share my screen here and get started. So I am used to, in presentations, just if you have any questions or commentary, please put them in the chat. We're going to be monitoring the chat just to make sure some of the questions are brought forward. And I believe that my disclosures and about me was listed on the event invite, but I'll just go ahead and quickly run through those. So Laura McWilliams, I am a patient safety professional. I am currently a leader in development of a head and neck surgical oncology practice. I have spent some good time in management, leadership, administration, over an acute care speech pathology team, which I absolutely loved. And I am receiving an honorarium for this. And I'm very thankful for everybody who is donating for Hurricane Helene survivors. Our community is absolutely in the trenches of just recovery. It is true what they say about a Hurricane Katrina comparison. And while this is not focused on that, I'm more than happy to talk about that and to continue to raise awareness to that. And thank you for supporting my community. So safety, standardization, Swiss cheese, and the speech pathologist. So some of my other disclosures are I do have my own consulting business. I am a co-leader of an ASHA member advisory group on patient safety and quality. You should consider joining. And I am now shifting gears into some nonprofit work related to my current experience. So with this type of session, I want everybody to go into it open-minded. A lot of the content we as speech pathologists often pursue is very linear and very specific to types of specialties, types of treatments. And I want us to just get a little bit broad and frame your approach to this content like you are a caring professional in healthcare and or education or private practice, and just be broad. Ask yourself, how can I bring this back to my industry, my specialty, my business? Keep it broad. Have a generalist mindset and approach these concepts with an infinite improvement mindset. So those things right there will start setting the intention and the tone in your brain for how to look at safety science and embed it in your day-to-day. Okay, so I'm going to just go through some history because you cannot start talking about patient safety and quality without recognizing where we have come and some of the major influences that has impacted where we are today. So a history lesson, when we used to think of quality, the old definitions were often, it was quality, it was good craftsmanship because it was done by my hands, it can withstand the test of time, durable. Safety, old definition, is freedom from harm or danger, protected from or unlikely to cause danger, risk, or injury. Those definitions are very minimal and very specific to earlier, more early 1900s. Now, safety and quality in healthcare, aviation, engineering, occupational health is really about prevention, system thinking, and risk management. So years and years ago, in the early 20th century, patient safety and standardization science really started by something called the Flexner Report. It is a project sponsored by Andrew Carnegie, which essentially pointed back at medical training and physician practices and identified we have wildly variable practices. We don't have any standards for graduation. And we have a lot of people coming into this field without any really validated process. So I see this as the starting point for standardization and the start of us being able to talk about patient safety, because this point in time really took a hard look at the physician training in our medical community and said, what are we doing? How are we doing it? Is there an evidence-based process to take a look at how we're teaching professionals? Are we aligning colleagues in medical schools with expectations? Do we have a consistent approach to how we're teaching our generations of doctors? And so after this report came out, the vision was realized, like licensing strengthened, and treatments not rooted in science were rooted out. Instruction became more hands-on, and this really was a turning point for the discussion about the importance of standardized training and education standards. So this loose timeline, I'm going to take you through this. It overlaps because there are pivotal moments throughout the past 100+ years that really took safety science and quality and brought it to the forefront. So first we have our Flexner report. We have in the 1920s and 1950s, we had huge developments in infection prevention, antibiotics, antiseptics, and blood transfusion. So our medical approaches and nursing approaches really started to get better tools to care for people. In the 1930s to 1960s era, we actually had a rise in hospitals because with these advancements, we were able to develop units where they used to be wards or clinic-based care to actually have arenas for more intensive management of various conditions. So this was really the start of hospital-based care. In the post-World War II era, it kind of lingers on with an impact for quality control adopted from aviation and manufacturing. People looked at these industries and these systems thinking advancements that we saw out of the post-World War II era and started to adopt some of these practices into medicine and into how we deliver care to people. In 1970, there's a lot of people that have heard of the the landmark report to err is human, but in 1970, it was really the first publication. It's known as the Harvard Medical Practice Study. It had a delay in publication and it actually came out in 1991, but it was the actual first landmark assessment of what is the care we're providing doing, and is it causing harm, and what level of negligence is happening in the care we're providing. And then it basically was the foundation for the landmark book To Err is Human, which found over 98,000 deaths in the US were due to preventable medical errors, and also proposed a solution and foundational framework, which we now know as quality science. So the 2000s to now, we have many patient safety organizations that have started. We have national patient safety goals. We have Joint Commission's toolkits, checklists. We have the development of value-based care. And we have groups like the Institute for Healthcare Improvement that are really paving the way for this new science. So one thing I want speech pathologists to really embrace is, I think sometimes we say, well, we're a relatively new field, compared to physical therapy or compared to nursing or compared to physician practice. Well, patient safety science is new too. And a lot of it is driven by technological, social, and medical advancements for us to get good, standard, and consistent with the care we're providing. So we're right on track with it. Also, throughout this time, we need to remember that we have Deming's principles that started throughout this era. This is a very specific type of business and industrial revolution approach to processes and lean management that happened at this time that really impacted a lot of the innovation and organizational processes with reducing waste and improving safety. So when we look at modern, the Harvard Medical Practice Study, really quickly, they looked at discharges in 1984. They estimated that they had 98,609 adverse events out of 2,600,000 discharges. They also found that about 56% of them led to minimal disability with complete recovery in 1 month, which is a significant number. 13% led to moderate disability, 2.6% produced permanent total disability, and 13% led to death. That was just adverse events. When it came to negligence, this was the first study that actually looked at negligence. They found that out of the 27,000 injuries, they had 6,000 deaths, 800 cases of permanent and total disability resulted from negligent care. So this study is really interesting to be looking at the data because it was one of the first ones to get really into the nitty-gritty details and see where are we starting and how far we have come. And then again, To Err is Human and Is the Needle Moving are just landmark articles, and they are in my references. So timing cycle, I'm jumping to this because again, come from a broad perspective. This is he was an influential businessman. He was one of the scientific pioneers of quality control. The term quality really shifted from that old term of, was it good quality, sturdy, hardy, and made with my hands, to are we quality testing what is being done is safe and efficient for whatever the goal is or that we are developing or creating. So if you've heard of the lean management process, the Toyota model, total quality management, his approach to operations, whether that be in aviation, healthcare, engineering, I'm talking like nuclear engineering, is that processes and the absence of processes that are good, standard, and safe is really the problem and not the people. And when I started my own learning journey of how to improve my team, my care that I'm providing, I found that his approach to continuous quality improvement really spoke to how to approach evidence-based practice and team dynamics as it relates to improving the care your team is providing. And I just love this quote by him. 85% of the reasons for failure are deficiencies in the systems and processes rather than the employee. The role of management is to change the process rather than badgering individuals to do better. He is also the grandfather of the basic concept plan, do, check, act, which is the PDSA cycle. And that is the foundation of the continuous quality improvement. So what it is it's a continuous cycle. It's an infinite game that if you have an issue or a challenge, you're approaching it, it is your job to approach it as if you are continuously improving it and keep refining it until you, as you move towards the goal of finding the most perfect system. Okay, so why I get so excited and how our definitions have changed from quality and safety and what that means for you. Quality healthcare means doing the right thing for the right patient at the right time in the right way. That is our hospital healthcare evolution of quality from national quality standards with Joint Commission. Patient safety practices protect patients from accidental or preventable harm associated with healthcare services. The intersection of those two results in healthcare quality and safety as a field of study and prevention of adverse events, suboptimal care, ineffective treatments, inefficient processes, and unnecessary clinical variation in health systems. So I'm going to pause there because once I found essentially that definition of healthcare quality and safety science, I was sold. I was done. This is it. This is what I've been looking for. This is what I care most about. And I think what a lot of speech pathologists in various sectors of healthcare or education or private practice really care deeply about. We care about the adverse events, the suboptimal care, the ineffective treatments, the inefficient processes, and the unnecessary clinical variation that we see among our patients, their outcomes, and in our institutions. And then I realized this is an actual science. This is a science of study, and how can we apply this to our day-to-day? So my mind was blown, and I knew this method and this methodology behind safety science could piggyback with reducing adverse events, reducing suboptimal care, improving the care our teams were providing effective and timely treatments, and reducing that clinical variation. So I just want to pause. Are there any patient safety professionals in the group? Feel free to type in the chat. I know I'm sharing, but Shannon, if you could let me know, I'd love to know if we have any on today.
Yes, I'll let you know if anybody includes anything.
So the Swiss cheese model, and if you've heard of this, that is great, because I think sometimes it is tossed around as, well, that's the Swiss cheese. This is a very common concept in nursing leadership. The professionals that are really the backbone of patient safety is nursing. And we as allied health have such a respect for the nursing profession, because they are the most bedside clinician and patient-facing professionals that are taking care for our patients. They are the backbone of healthcare. They are the largest body of professionals in healthcare. And the fact that they have developed this or adopted this model to help with root cause analysis and reducing harm to patients is so powerful. So I'm going to walk through this because it's really, it's important to understand that every time we approach a patient, there are so many layers of defense that is in front of them for us to do our jobs well and right and good, no matter what your role is with that patient. So the hard definition is it's representing that the layers of cheese are defenses that should work together, that if an error happens or something is wrong with one layer, there is another layer of defense that should replace or stop a negative consequence from happening. But often whenever a patient safety event happens, they review the incident and find that there were multiple places of defense in place that didn't catch the event, or didn't catch the miss, or didn't provide that defense that was needed to prevent harm, and step outside of 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 healthcare and think about this from a if you were working in a business that works with a lot of chemicals, you have a lot of processes to keep chemicals separated, to keep you protected. And if you accidentally have a spill, there would be an analysis of how there was a breakdown to get to that point that a chemical was spilled and there was a potential toxin released into the environment. They would review where that layer of Swiss cheese was broken down, but it is a brilliant model, but it is fragile, because once that one layer is identified, that is the point of weakness that needs to be addressed, and often can uncover other points of weakness in other types of treatment. So it's very handy when small missteps may lead to great failures. So for example, I'll have tangible examples coming up next where we walk through this. So this is an actual patient safety event known in the UK, named Baby Leah. She never disclosed her name, but when she was admitted into the NICU, her first layer breakdown in receiving the correct medication was a medication order was entered, but the wrong weight was input in the system. So that's one layer of human error. And then the pharmacy did not do their normal check on that medication. They did not verify the weight because of staff shortage. It was overlooked and it was approved. Then nurse administration relied on the automated system. They had a breakdown there. They relied on the automated system to say, hey, it didn't flag that anything was wrong. I guess the weight is right. The medication has come up. And they did not manually check that it was accurate. And then the monitor. So this baby had a monitor that wasn't in the right place, the probe wasn't in the right place. And it actually did not alarm that she was starting to have an adverse event. She was starting to decompensate. So she did pass. And this is one of the more modern examples of the Swiss cheese model and the breakdowns and how the layers did not catch. So in the aftermath of this, they took a look at each layer of the Swiss cheese, identified improvements for each one. And you can definitely see that human error at the beginning of the adverse events and how reliant we are on the systems around us, the socio-technical systems, to make it hard for us to do the wrong thing. Okay, so this was actually an experience for myself. I worked in graduate school. I went to the University of South Carolina, go Gamecocks. And I had the privilege of working with a little girl who found her way back to the clinic, and she was terrified of her cochlear implant. She was initially seen at a different clinic, a different university, and during her initial mapping, the map results were wrong. There was a tech glitch, and her setting in the initial hookup was wrong from the beginning. And now I'm a speech pathologist, did not go to audiology school. It's been 10 years. So my telling of this story is probably degraded from my audiology knowledge, but the patient safety event is still, this was a real event in my life that I experienced with our clinic whenever I accepted this person as a patient. So one of the other layers of breakdown was education was not verified to the team members and to the family. There was a staff shortage, and basically this patient, this little girl, had a different family member that came to each session with her, just from different family structure and status. So that was a layer of breakdown. There wasn't that continuity of people to teach about the cochlear implant and then teach if something seemed off with it, to have that good patient family feedback loop. So there was some miscommunication with school carryover, and they started to use the cochlear implant as almost like a punitive type of tool. And then the last layer was that the monitoring systems. She was lost to follow up, and she actually did not follow up with her audiologist and cochlear implant team for about 3 years during a very critical point in language development. So, you could see the patient safety and the Swiss cheese that she went right through all the different layers and the catches to stop a series of events like this. This is another event that was a patient that I worked with that actually was one of the examples that helped my institution switch from the national dysphagia diet to the international dysphagia diet. So I had an individual who had a severe brain injury, survived, and he just had very aggressive physical tendencies, and he had a very difficult time getting supportive discharge placement. So it was one of the most heartbreaking brain injuries I think I've ever worked with. And the diet order that was entered under the old standard, not even standard, but National Dysphagia Diet language, which, as we know, has a lot of variance in it and a lot of room for error. It didn't default actually to the correct level because of some of the self-modifications that were still permitted at that time because it wasn't a standardized diet method. And then he had variable caregiver support who didn't understand his swallowing disorder, didn't understand the cognitive aspects of eating and drinking for him and how to keep him safe. And then an unfamiliar caregiver allowed a food that was not safe for him from poor communication and poor understanding of what was entered in the computer. There was no check for what diet he was on and what he needed to be safe. And after he started to choke on the food that he was given, and he was asphyxiating, and there were no alarms that were connected to his room at the time, also because of some things related to his brain injury, which were difficult, but that was definitely a layer. Not even the camera or the motion alerts were on to support something was off, something was wrong for him. So he ultimately did pass, and he did receive his case did receive an entire patient safety review, a root cause analysis, and this was his Swiss cheese breakdowns, these 4 points in the system. Since then, we have transitioned to the international dysphagia diet. We have better verification for diet orders. We have improved communication for feeding support, and I'm hopeful that we would have better monitoring systems for him, for somebody like him. Okay, so I'm going to shift gears a little bit to our next topic is commitment to identifying the Swiss cheese also improves your communication of what do we do around here, why do we do what we do, and how do we talk about things that don't go quite right. So here are some good resources and good terminology to use when you're talking about patient cases that might not have gone in a way that is supported by evidence or might need to be reviewed. So the first term, the after action reviews, actually comes from the military. Every time and a lot of leadership and quality and safety practices come from military strategy, military knowledge, and repetition of working towards a more perfect system. That was Deming's whole premise when he's looking at systems thinking and design thinking of how to improve whatever we're doing towards impacting people, keeping planes in the sky, helping people be safe, and doing more quality work. Is how do we sit down and how do we review this process together to work towards a more perfect system? The root cause analysis, RCA2, I have a resource in my resources, the International Association for Healthcare Improvement, the IHI, is just a wealth of knowledge and it's free. Please log on, please create an account, and please start looking at their toolbox. It will help you with the language to start using and also how to start approaching safety and quality at your facilities in your role with a more methodical approach. And I think even just saying, is this the Swiss cheese patient? Did this patient just bring up a lot of breakdowns in our normal processes? Helps to give you the language of, this isn't a person issue. Is this a process issue? Do we have a breakdown in our processes, whether it be from a referral source from the NICU doctors, whether it be from a processes related to how our diet orders show up, processes related to our trach teams. Is this the Swiss cheese is just such a powerful statement because it immediately takes the pressure off the individuals that are supporting the work and starts pointing to the process. I also love this quote as it relates to standards, because as you can see, if we're looking at Swiss cheese and the layers of defense that might have breakdowns, often some of the reasons for that are non-standardized care practices. So this quote from Ben Horowitz, there's a saying in the military that if you see something below standard and do nothing, then you've set a new standard. So when you see a breakdown in care and you see a potential Swiss cheese, you need to be talking about that as an individual. If you're a person of one, with your immediate group of support for clinical decision making, with your team, with your extended team, with your division, with your extended hospital team, because that is your standard when you do nothing about something below standard. Okay, so from stalled to standardized, I am going to really, this could be an entire talk in and of itself of, what is clinical variation and how does it relate to patient safety? So there are technically 5 categories of clinical variation as presented to the Senate Finance Committee related to healthcare and healthcare standards that are costly for the care we deliver to Americans, because this is the U.S. Senate Finance Committee. The 5 categories of clinical variation show up in these ways: misdiagnosis, mass variation in clinical practice. When you have clinical variation, you cannot really validate that you are providing best clinical practices. High rates of inappropriate care, patients receiving care that they don't need, therapy that they don't need, not getting treatments that they do need because we're providing different treatments, unacceptable rates of preventable care, and that results in patient injury and death, striking inability to not be able to do what we know that works. When you have such clinical variability among a single building, a hospital, a clinic, or even an extended series of healthcare related buildings that are in like a division or whatever, you have an inability to actually do what works whenever you have such clinical variation. So this, as you're looking at the cause of clinical variation, what you are asking yourself and your teams to start embracing is a high reliability and high transparency culture. And what that means is, how do we know what we're doing is current, sound, and updated? And how do we know it's consistent among all of us? Those are 2 things that have to be in tandem for you to have a high reliable, high transparency culture of what we do. Complexity, the clinical uncertainty in the context of primary reliance on human memory, the craft of medicine, rehab skill, and low transparency is linking clinical choices to patient outcomes and routine practice. So when you're looking at this statement of what is clinical variation, when you are providing complex care, which I believe that rehab allied health professionals, we are looking at so many factors related to patient safety and what makes somebody successful in their rehab care plan. If we only rely on our human memory of what we think is right instead of a standard protocol or a standard approach, and then you don't have any way to really track, is it making impact except for a subjective observation, you don't have a highly reliable and highly transparent culture. So turning that in our complex healthcare system, We need to be working towards standardized, protocolized, easily uh, packaged approaches to why we are about to do what we're doing, which is a type of therapy, with high transparency of why we have decided to do this. A lot of discussion of why that is our clinical decision making. So when you look at doctors and you look at surgeons and you look at things like tumor board and you look at um, uh, even just aviation. Aviation is talked about a lot in patient safety or human safety because the stakes are high. If we get it wrong, the plane falls out of the sky. Surgery, if you get it wrong or you have the wrong surgical approach, that person might not be able to swallow again, or that person might not survive, or they might not have an outcome that is really aligned with the quality of life that they want. As allied health professionals, we sometimes move away from that responsibility of making sure that our decisions are just as in line with some of the high stakes, high risk situations like aviation, like medicine, because we really believe, and I believe that we have some of the most impact on people's quality of life and their safety as it relates to voice and swallowing diagnostics. So adopting the high reliability, high transparency culture is critical for you to be embracing patient safety and quality culture. Okay, so money matters. This is just some whole facts about that. So whenever you look at the money and the waste, when you have non-standard practices in healthcare, I'm not just picking on speech therapists, the resources expenditures, the waste associated with non-standardized practice is a lot. 65% of all care delivery spending is quality associated waste, variance, non-standardized, energy wasted, unnecessary treatments, inefficiency to getting to care, recovery from care that shouldn't have been provided. We also have to remember that when we're looking at standardization, what we're also doing is we're being kind to ourselves. And we're saying, hey, I think there's an easier, better way for me to do this. And I love working with therapists that say, I have to have a checklist for that, or I need a protocol, or man, this really needs to be put into something, because what they're saying is not, I need some help, or I might have, some brain changes going on. What they're saying is, I need to reduce the energy in the brain burn and make this easy, standard, and repeatable so I can do what I was trained to do, which is provide good care and use that data and use that information. And what that is it's built off of research. It's built off of experience. It's built off of the grandfathers and the grandmothers of our field and the modern researchers who are updating their protocols. What we're doing is we're bringing that into our care, and it is okay to do that. So when you're looking at the mind games and you're looking at what we can remember, the magic number 7 ±2 is really our limits for capacity for processing. And this is a really common point, and it's from 1956, but it comes up again and again and again when it comes to high stakes medical care, and also why we are looking to improve it. We simply cannot retain and process all the information we need to provide the level of care that we are holding ourselves accountable for if we are providing evidence-based practice to our patients. We need protocols. We need to make our protocols across our teams standard, repeatable, and easy. So this is also a statement that I say a lot on my own platform, social media. The key to effective variation is standardization. When you're looking at patient safety and quality, and let's say we're stepping into a surgical arena, and you have your specialties. You have your cardiovascular surgeons, your head and neck surgeons, your orthopedic surgeons, and you're looking at the surgical approaches to what you're doing with patients. There all is somewhat of a standard of surgical approaches. However, there's the need to vary depending on what is in front of you, the bones that are in front of you, the arteries that are in front of you, and what is happening with the patient in that surgical arena. Now, I'm not going to say that all surgeons are standard and they have the most standardized practices. I think that actually is one thing that the surgery community is working to improve, but there still is a roadmap for the basic surgery that they have specialized in or do repeatedly. And there's literature that if you do a procedure 50 times a year, you are more safe than that person who is only doing 49. And it's that repeatable method, that repetition that makes you better and good and more precise at it. So when you're looking at how to make it easy, there's been years and years and years of surgical evolution of what are the standard approaches to operating on your shoulder, and then when are the cases to vary. But we can't vary safely unless we have a standard approach of doing something consistent repeatedly every time. I introduced myself as working in head and neck now, and I started my career in that. And one of the things that I absolutely love about it that some of my mentors have said to me is when you're changing a voice prosthesis, you ask the same question, you run through your same protocol, and you do your same tests every single time. And if you do that and you repeat and you repeat and you repeat, you will notice subtleties and you will notice variance, and that will be signs. What my mentors taught me is standardization in the start of patient safety and how to do better with a roadmap of consistency and standard approach to care. So a key to effective variation is standardization. We need to standardize before we can effectively vary. All right, so this is an article that I have linked later on. So I'm going to talk about the ventilator because this is more standardization, education, and I love this example because I think we use the term best care a lot. So this is at a hospital in Utah, Intermountain Health. So there was a landmark study about how to basically develop more standardized approach to medicine. And does that save lives? Does that save money? And does it improve care? So I picked the ventilator because this just speaks to me as a critical care speech pathologist, now clinic outpatient. And I just think that technology is just amazing. So did you know that we have about 46 physiological aspects of our health condition that a pulmonologist and respiratory therapist have to know to appropriately ventilate and support our lungs? There has to be understanding of 46 elements of us humans in critical care in a bad way for them to get it right. And until this study, they really looked at best care protocols, and what they found is people were relying on old rote memory of this is what I learned, and I'm going to apply this change to the ventilator here and this change here, and I'm going to look for this loose indicator here. And they noticed a lot of variance across what they were doing. And this is just some examples of why best care protocols just are really not hitting the mark, because they're not necessarily giving a real roadmap and constraints to what we should be understanding about what's in front of us, in this case, the human body, to know when to standardize or when to vary to support the person in front of us. So the solution is they implemented a protocol using Deming's approaches to reducing waste and improving quality. They used his principles. This is the body of literature that talks about it, how Intermountain Health trimmed care costs through robust quality improvement efforts. And The Machine That Changed the World is a great article to read if you just want to dive a little bit more into this related to ventilators. They built clinical workflows, and they made the providers have automatic rule-ins, unmodified, and clinicians were then encouraged to vary based off the patient needs. But they had to start in that automatic clinical workflow. That was their starting point. Variances in patient outcomes then fed the feedback loop. So if you have that baseline, and then you have that outlier, and then you have another outlier and another outlier, what you're actually doing, and you're feeding that back to the original protocol, is you're making the protocol better. So that original baseline started to shift and started to change to just provide better modified care. So what they found is the survival for ECMO and improve. I have this in my way. From 9.5% to 44%. Costs fell by 25% per case, and physician time to think about those 46 physiological indicators, their time fell by 50% to get it right. And to me, that's just incredible. So the importance of innovation is standardization. They learned and they got better because they first standardized what they were doing. They developed a shared baseline. If we're going to provide care for acute respiratory distress for a person who requires ventilation, we are developing a clinical process model. And some of you have probably heard CPMs in the nurse world and in the physician world. What is that clinical process model? Well, what it is it's a shared baseline built by evidence and then blended into clinical workflow to get a consistent feedback loop of, is it modifying and supporting all of the patients? And that's how the acute respiratory distress clinical process model was the baseline. And now we have these very specialized ventilation settings to support the most subtle differences in patients. You have to demand that clinicians vary based on patient need, but you have to start in that standardized place, and you have to have a very good reason to make that modification. So it's by forced function asking you, hey, I have to have understanding of why we start at this place and why these are the parameters that are good and right for the lungs. And if I'm varying, I have a very good reason to question that shared baseline and make that accommodation for that person, for those lungs, and see if it works. So the feedback data is the lean learning loop, and that's that plan, do, study, act. So with that feedback loop, they have continuous cycles of improvement towards the most perfect care. So when you look at technology, this is truly how we got from the old ventilators that just did basic things to the machines that we use today. Actually having these shared baselines, knowing that these slight modifications actually is what pushes technology to advance and to change and to meet the needs of not just the clinician, but the patient who needs the subtleties. So this is also a breakdown of just Deming's system of profound knowledge. It's a systems-based approach to process improvement. I'm going to go through this quickly, but I think it's worth everybody who is in a leadership or a clinical lead position or trying to lead an initiative, and you're running into some good barriers or maybe resistance among like-minded clinicians that might just have varied practice. So you have to come from an approach that you have an appreciation for a system, that you are understanding the need for variation, and that the theory of knowledge, that we are using evidence-based practice first while committing to continuously updating our practice. Even just saying those words can be really scary for some clinicians in some environments. But believe me, once you start embedding them into your daily workplace, into the discussions among clinicians, and then also understanding that if you are coming from a place that fosters collaboration, it will reduce fear, especially if you're welcoming the discussion of reviews of patient cases, not from a punitive place, but what about reviewing cases of things going right? Is that your protocol to just put into place to improve what you're doing with patients? Because if you reviewed something that went right, you might have found a new foundational baseline to start discussing across your teams. So hang in with me here. I joke on my own social media that I'm low quality graphics, high quality content. So hang in, because I in standardization, in working towards your team having a more specific and intentional approach to what you're doing in your care delivery, actually fosters the innovation to improve the care you're providing. And so my husband's a musician. I often think of an orchestra when I think of standardization, and I think of music a lot. I can't carry a tune in a bucket. I go to the shows, I support it, but I just think it's beautiful whenever you watch an orchestra all come together, and you have the person who's playing the violin, who's helping everybody get in tune. That is truly standardizing and getting the group more towards a norm, more towards a center. And what they're doing is they're preventing the outliers. They're trying to catch the outliers and bring them more back to neutral and back to this place of harmony. And I want to also say that some of these outliers are people that might not be as committed to the mission, or might not be as committed to the group, or maybe have just lost their passion. And still, it's really important to help the group be more unified and harmonious in the care or the music we're providing, because that flat note is going to be heard in the audience. And that flat note is actually the example of what your department or what your field provides, right? So it's very important that groups are working together to shift together in their standardized approach to care. So I also want to leave room for the innovators, because that person who's out of key or might be in a new key because they hear and see that there's potential in that key, actually are people that aren't necessarily outside of the harmony, but they're trying to expand into a new realm. And it might feel dangerous and it might feel different, and it's not wrong, but what leaders and what your teams have to be vetting is the intention there? Is the intention there to do what's good and right and best for the patient, and for the good of the group is a term I use a lot. And keep thinking about that. Keep thinking about that note, because in that person, because it might not be, what is harmonious now, but there's something to it. To me, these are the people who are coming to me to say, but have we tried? Why haven't we adopted MBS-IMP yet? Or let's really talk about esophageal visualization in what we're doing. Or, man, we really need to embed this questionnaire into our daily practice, and we all need to be discussing it because it's so good. Have you seen the data on it? Have you seen the impact it has? Did you see that patient that we caught that issue with, right? Like that, those are the keys. That's the beauty of innovation, is you have to have an idea of what works and is good and is standard while also embracing the new concepts. Because what comes is, okay, then we have a few people learning and adopting and then innovating. And then eventually the group has shifted because we are able to say, man, that is something we want to adopt into our practice, or it made us safer, or it's something we should have considered all along over here in this orchestra, and it's with good intent and it's with good outcomes, and we're going to use Deming's cycle of planning, doing, studying the impact, and then acting and continuing to get better and better as we go. And and as the wife of a musician, and also just appreciating music, is this is how you get things like old time music to rock and roll, right? You have those segues of just amazing music and art, and science is art, and that's how we have the branches of the different specialties and have developed the innovative therapies in front of us. So we need all kinds of kinds. And when I talk about standardization and I talk about patient safety, sometimes people say things like, oh, but that's cookie cutter practice, or I have my own license, I stand on my own feet. And while that is true, we also have a responsibility to make sure the patients in front of us and connected to us and connected to our greater practice. All of you are in my greater practice. I've received reports all over the country throughout my career. We're more interconnected than what we realize. That we are also working for a more unified approach to whatever our specialty is. And we are owning the responsibility of continuous quality improvement by embracing the new, embracing the researchers, embracing the patient that pushes the norms. But we have to respect the process of standardization to get there. So patients guide, research, research guides, protocols, protocols guide standardization, standardization guides technology. Shout out to Tim's. I know I'm welcome to be part of this conversation, but Tim's has revolutionized my team and my practice by bringing standardized tools and protocols in the computer. And when I discuss, why we should adopt MBS-IMP and why we should be looking at VACEs, well, it's built into our technology because it's become a standard of dysphagia diagnostics. So when you're looking at the technology also adopting to our standardization and our protocols, it's really hard to face when your technology is changing to support your practice to not adopt the better practice. So thank you, Tim's, for just innovating along with us. Technology guides standardization. Technology creates the feedback loop. I think it's wonderful that different platforms are now filtering back all of this great data as it comes to voice and swallowing diagnostics, which also supports innovation. So challenges and solutions, I'm going to go through this. So some of Intermountain's solutions with the ventilator is having that high reliability process and that standardized, that baseline, that shared baseline. So for me professionally, as I am on my patient safety journey and my leadership journey, these are some of the tools that I have done in the workplace is developing foundational articles. When you are onboarding, it's so amazing. It's so amazing to onboard people, and we have to really take responsibility for it, because when you're talking about what do we do around here and why do we do it, your foundational articles, what's the literature that is the basis for what we do? And for example, the recent best practice articles in endoscopy and fluoro are some of the foundational places that I ask colleagues and clinicians to start with. And we as a group have decided this is the start of our best practices, the most updated articles for that. So you start at the hospital I work at and you read the foundational articles and you're already setting a tone that this is kind of a benchmark for practice. Competencies, love them, adopt them, make them annual. That's your opportunity for a feedback loop. That's your opportunity to standardize, and that's also your opportunity to adopt something new, especially if you have annual competencies. I love competencies, especially annual competencies, because it helps us talk about what we're doing. It helps us talk about swallowing, talk about voice diagnostics, language diagnostics, and it also helps us develop better tools, because sometimes your competency from the year before just isn't cutting it anymore. And then it becomes a group decision to improve it. Consensus to practice. So we have a lot in our field that is still up for debate, right? So what do we do with ACDFs? I just threw that out there, but there's a lot of good research coming out on it. Thank you to the researchers in New York for all that you're doing to help us with that. But for a very long time, what do you do with a fresh ACDF? What is our consensus to practice with this specialty, with this surgery, when a patient has postoperative dysphagia or preoperative concerns? If you have a subgroup or a consistent pattern of care that is very challenging for your team, sit down, talk about it, talk about what can we do to be a little bit better today, and what are we more aligned with? Because remember, we're consulted to solve a problem or answer a question. And if we're all showing up very differently, that consult and that question is going to stop coming to us because we're not approaching it from a unified place. And that's where you get the statements like, well, their practice and my practice, it is just different. Well, that's not acceptable when it comes to healthcare, because you don't walk in to a nurse's station or to somebody placing a PICC line and say, well, their approach is different than my approach, and I don't use the technology and she uses this. There's protocols. There's standard approaches to everything, most things. but especially in things that should be considered more, I'm going to say routine. Speech pathology is not routine. But when it comes to diagnosis-driven issues, and especially iatriogenic secondary conditions like swallowing, swallowing secondary to another medical issue, we need to be very careful that us as a group and as a field are approaching diagnoses more consistently than not. Okay, so toolbox. So I know this is gonna, I know we're running out of time, but I wanted to talk about this. So if I could say anything to myself before my patient safety journey when I was just embarking on it, is you need to be looking at, from a patient safety standpoint, from standardization and care, getting everybody more aligned, and also working on continuous quality improvement, is really looking at your toolbox for what are you doing at your workplace with training, competencies. How are you asking questions about this? How are you making decisions based off of that? How are you documenting it? Because that tells the listener or the consulter how good is your training, competencies, intake process, and decision making. Your documentation does. Your care follow-up and your quality control. How are you looking at your approach to this question? Rinse and repeat. Same thing with swallowing. Take a look at your training, your competencies, your intake process. And when I say the intake process, I mean, if one therapist is asking, are you losing weight? It's very different than somebody saying, how much weight have you lost? And so when you're documenting patient lost weight, both of those people, you actually ask two very different questions. And when it comes to data and information leading towards a solution or leading towards a care plan, subtle differences like that could actually be a big difference in the outcome or what the patient receives. And also it shows variability among clinicians. I could take this broader when you're looking at swallowing diagnostics. If you have clinicians who use MBS-IMP and then not, and you're a consulting provider or you are giving information back to a group of neurologists, that's confusing. Why are we making decisions based off one thing and not the other? I love the digest. I love tools that just help to make it easy for me to make clinical decisions while I'm also looking at the human in front of me, but taking all of this data to help the care plan move forward in the most meaningful way. Make it easier on yourself. Adopt the evidence-based practices, which are protocols, to help make a more sound decision. And what I want to call out here is the protocols and the more standardized checklists. Like I had a nurse today say in a different presentation, I love a good checklist. and what that really is, when you look at electronic medical records and you look at some of the data that's already put in different ways, is already embedded data that a lot of physicians and doctors use to make a better decision. So when we're getting more standardized information about the patient, whether it be through questions or documentation, what we're seeing in the documentation or the diagnostics, we are piggybacking our standardized approach to an already well-established medical critical thinking approach, which is looking at specific data points for decisions that we're making. And that's what I ask of all of you. So this is this isn't everything in my head and neck cancer toolbox, but when I was talking about that same process, that same approach every single time, there's things that I need to add here. This is like I'm meeting a patient with a new diagnosis of a head and neck cancer, and I'm doing all of these things with them every single time when I'm doing a clinical swallow evaluation. And as I'm getting all of these data points, if I were to have a colleague or somebody down the line who wasn't doing these same data points or getting the same information, I might not catch subtle variance in what's going on with them. I might miss a big change. And I am one of the connections to help the doctors know, are they truly in survivorship or do they have a new symptom? So just take that with you. With your kids, if you work with kiddos, peds, it's very important to just be more methodical about how you are approaching your patients. So I'm about to end and then we can go to questions. I think we're close to time, but we need to normalize. Do you mind sharing your protocol or guide or your consensus? It's gonna feel like you're stealing the secrets, but what it's doing is it's just pushing us more towards a better and more perfect process. And it's also helping you to expand your network and helping you be more interconnected and less alone. So carry this on to other aspects. If you have equipment, do you mind sharing how you got there? Share your proposal, because guess what? Securing that equipment, securing that device, securing that scope, securing that new C-arm, securing that new TIMS, that's going to help your group move more towards standardized and safe care. Sharing should be open. You updated your trait competencies. There's such great work behind that, especially if you are a team that just did a lot of work into updating what we do around here. Share them, use them. What you're doing is you're sharing a baseline. And I think ASHA has some really good tools when it comes to the dysphagia verification, DCVT. I know Dr. Hazelwood's done a lot of work on that, and I think that's a really great place. And it doesn't get as much recognition, some of their competency tools on the website, because it is a shared baseline that we all should be taking a look at to see how we can adopt that into our locations. And I encourage that because that's where a lot of our competencies were built from. Okay, so high reliability tools, shared documents, foundational models, getting frame by frame analysis, having calibration sessions. I've talked about this with TIMS, and that's something that I am committed to bringing into our field, is really having sessions where we're sitting down and saying, are we calibrated? Are we standardized? Are we all pointing at the screen and saying, that's the epiglottis, or that is aspiration, or what would you give this on the digest score? What would you rate this as? The more discussion about that, it is really improving our ability to talk about what we do around here and helping us be a more safe field. You have to be a culture committed to quality improvement, and those have to be words that come out of your mouth on a daily basis, especially when you notice variance among practice and you start this journey. We can do this. Like I said, if the tech advances for this standardized score and protocol, don't you think we should consider it too? And this is just something that I love from one of the grandfathers of patient safety, which is better has no limit. It's an old Yiddish proverb, and it's the basis for continuous quality improvement. So my references are all in the PowerPoint, but here's the big ones that I've mentioned all throughout this webinar program.
All right, thanks so much, Laura. I appreciate that. So we have a couple comments and a couple of questions in the chat. So to start with the comments, so somebody said they agree that the IHI is a great resource. Somebody else said that they love the idea of having foundational articles during onboarding. They do this for students and CFs, but liked the idea of having it for new hires during onboarding. And then over to the questions. So the first question is, at what point do you separate standardization with being a technician?
So that is actually a really great question. Because there is that, I think I said it earlier in the session, there's this socio-technical aspect of when you're developing a standardized protocol, you're doing things to collect specific data, but there's still that human factor to it. This is kind of flirting with the concept of what is AI bringing us, or what is big data bringing us when we're looking at patient information, the medical indicators of patients, and then what is the human doing to really take that information, make a good decision, or take the next step. So you are actually developing a repeatable process to get specific data points that is helping you be a better decision maker, and that is not a technician. The technician could help collect some of the data, but what we do with it, what it means for us, what it means with the person in front of you, is really the beauty of having that baseline of the standardized intake or data set to then make the best decision possible, while also adding more data points in as we learn more about whatever it is you're trying to impact or solve. So that is a great question.
Thank you. And I believe just the last question we have here is just the links that you mentioned in your resources. So if you, oh, looks like we've got one more question came in. But if you could, oh yeah, that's perfect there. And if you want to send these to Brooke too, we can get these posted with the replay link as well. So that way people can access these.
Great. In that, To Err is Human, if you go to that link, the book is free to download. It's open access. So you could start your patient safety journey and quality journey tonight by downloading that book and starting to read.
Perfect. And we've got one more question before we wrap it up here. What do you do with a team member who refuses to conform to standardized approaches when counseled and provided with resources and support? They just want to do it their way, even when it's different from the agreed upon team approach and no longer best practices, essentially not a teachable employee.
So that is a common question. And I think that does come down to leadership being engaged and committed in the discussion about practice, what we do around here, stripping it down back to that that high visibility. You have to have highly reliable practices, and then you have to have visibility of, are they in place? Are they impactful? And then visibility of when there is an outlier. Okay, so this is where the consensus to practice documents come into place. So for example, I worked with my former group on just some of the same things you're describing on esophageal visualization. Why do we need it? Is it beneficial? Is it outside of our scope? There were essentially, I as a leader called, we have high variability here. This is a patient safety issue because it has caused some negative consequences, and it is not safe for us to be varied on this. So we as a group have to sit down and come together for a consensus to practice. Everybody is invited to participate, be part of the conversation. But part of this also is you have to show up to be part of the outcome. So sometimes that's what you're describing is often just general professional issues. And if it is somebody who is committed to doing good, is committed to what is in front of them, which is the patient, and you're showing up with support and good discussion, but also making sure we come out with an outcome as a group. If it is a person who is committed to the patient, they ultimately typically get there. But if not, that's more of a professional issue, and that's more of a safety issue that your leadership needs to manage. However, just the act of having consensus to practice discussions about what we do around here can help to push the group more centered and together, while also giving opportunity for some of the different thoughts and to be brought forward, while also holding an expectation that we will be making a decision on this and moving forward with that. And that's where a strong partnership and awareness with your leadership, you might be the leader, is important. So I'd be happy to talk more offline of just some of the strategies about that too, because that's something I've commonly navigated and had success with while advancing care.
Great, thank you. And two more quick questions here. How do you deal with costs associated with CEUs when trying to standardize practice? I'm MBS IMP trained, but it's hard to standardize that across a team when it comes at a high cost. So many CEUs have high cost, and since COVID, institutions are providing CEU funding less and less.
Yeah. So I'd say, if you're just trying to get people more centered towards a norm and cost is prohibitive, what is the free thing that you could also work towards standardizing? And if it is very important for your team to all be consistent with MBS IMP, and I come from a facility that covers the cost of it, and that was something that I worked on too. The business proposals sometimes take time, but I think even just working on standardizing other aspects of dysphagia or voice diagnostics can get people excited and self-motivated to seek that education themselves and pay for it out of pocket. While I hate that, but some of the barriers there also are related to maybe not quite having a strong connection to the why. So if you work on standardizing other aspects, the intake questions, we're going to give the EAT 10, the free things. There might be a little bit more self-motivation to take that themselves, or you might have a stronger group ask of your employer to have that covered, which is also amazing and sometimes more successful, because if it's one person in the group, usually you don't get it. But if it's all 10 saying this is really going to be impactful for us, that kind of pushes the needle a little bit more.
Perfect. And last question here, would you mind pointing us in the direction of the ACDF dysphagia research?
Oh my gosh, yes. I am going to forget her name. Yes, she is I think Cornell. She did a free webinar for us. I hope she's Brent at I think Weill Cornell. Is that where she is? Anyway, I will send that research along. It's in New York. They're doing a lot of research on ACDF, and I think actually, did she have a TIMS event? Maybe she was on a different event, but she's great, and she did a free in-service for us and just helped to share her knowledge and helped us come more centered in our approach to care.
Perfect. Yes, somebody just chatted Rebecca Bryn at NYU.
Yes, NYU. Sorry.
Perfect. All right. Well, that is all the questions. So again, thank you so much, everybody, for tuning in. And again, if you want the ASHA CEUs, please complete the survey placed in the chat. And if you need a certificate, email tims-univ@tims.com. And thank you so much, Laura, for joining us this evening. This was an excellent, excellent presentation.
And please reach out if you have any other questions. I can talk all day. Take care.
All right. Thanks, everybody. Have a good night.